Dear friends, we are back again, and today with a very interesting topic, and again very relevant topic as well. As you all know, the COVID cases are increasing almost all the states in India, especially in South Indian states. Also, the case numbers are increasing, and almost all therapies what we are especially the medical treatment modalities what we are using all are in a like experimental level. Still there is no strong evidence for any particular treatment, and there are many treatment modalities. We have initially started with like lopinavir or ritonavir, then we started using hydroxychloroquine. We have started even the hydroxychloroquine for prophylaxis. Then other antiviral drugs like favipiravir, then again remdesivir. In between, we have even used oseltamivir for some patients. And now we have other immunomodulatory therapies like tocilizumab, anakinra, steroids. We have plasma therapy also. So we have we have an excellent speaker to discuss all these topics, Dr. Jpse Chacko. Is very good in analyzing the literature and giving an opinion. Many of you might have read his blog. If you have not read, like especially if you're working in critical care, please follow his blogs. Like every week, he take a very relevant topic and he do a like literature review, and he writes about many topics. So especially trainees attending this webinar, please, I'll put the link in our page and our Telegram group. So please follow that blog. It's an excellent one. Like once you go through, you will understand that. And especially when you prepare some talks also, you can see like how nicely he is analyzing the literature. So today he'll be analyzing the literature on the treatment options for COVID. So over to Joe, sir. Joe, sir, sorry to interrupt. Can you just tell about that blog, sir, how to reach that blog?
Sorry. I can make a slide with the link to my blog site. So that might actually be helpful, isn't it?
Yes, sir, yeah.
Just a moment. So that's the actual website where I post my blogs. And if anybody is interested, I can actually send a link to all the blogs, including the very latest ones. So it is criticalcareblogspot.com. Okay.
Okay, thank you, sir.
Thank you. So shall we start? Can you hear me?
Yes, sir. Yes,
I
sir.
hope
Audio is
I'm audible.
Right.
I believe there was some problem last time. Hopefully, we will go through smoothly through this. So we are going through a difficult phase of COVID-19 in most parts of the country, including in my own city, Bangalore. And I'm sure the situation is pretty much worrying in Kerala as well. The number of new cases are increasing at a very fast rate now, although thankfully the mortality is not very high. But in a country like ours, with a population of 1.3 billion people, even a mortality of, say, less than 1% will mean a huge number. So that's the problem we are facing. And as you all know, in this disease process, we are yet to come across a definitive curative pharmacological option, although there has been some literature, which we are going to review now in the last few weeks, which offers some promise. And finally, there are many trials going on as we speak, and hopefully we will see some light at the end of the tunnel in our battle against the COVID-19 disease. So let us review what we have on the table at this time in terms of pharmacological options for the treatment of COVID-19 disease. First, one of the first drugs that drew interest was, as you know, remdesivir. which was used for Ebola virus infection, and it was not found to be beneficial in that disease, but now the interest has renewed in COVID-19. And there have been several studies which has addressed whether remdesivir may be a viable treatment option in this condition. It's got a very interesting mechanism of action. As you know, the SARS-CoV-2 virus enters the cell by attaching itself to the ACE2 receptor. Once it enters the cell, it literally hijacks the mitochondrion of the cell. The mitochondrion, which is the factory of synthesis of proteins, it hijacks the mitochondrion and forces the mitochondrion to replicate the RNA. So a single shred of RNA gets replicated by this process, and you get teeming millions, billions of viral RNA by replication, which invades other cells as well, and you have a florid disease. So how does remdesivir come into the picture? When you give it intravenously, it takes the place of adenine on the viral RNA. So it kicks out the adenine from the viral RNA and positions itself within the structure of the viral RNA. So during this process, the viral RNA, the configuration of the viral RNA changes completely, and it loses its ability to replicate. So essentially, remdesivir prevents replication of the viral RNA by taking the place of adenine in the nucleotide. So that's the way it works. So it seems to be a very plausible mechanism, and on the face of it, it looks like it will be a very effective therapy. What does the evidence say? The initial bit of evidence was from Wuhan in China. They carried out this double-blind randomized controlled trial. Randomization was done in a 2-to-1 ratio. For every 2 patients who received remdesivir, 1 patient received placebo. And the dose they used was 200 milligrams on day 1, followed by 100 milligrams from days 2 to 10. So that's the dose that they used, and they screened 237 patients, out of whom 158 got remdesivir, and placebo. In the placebo arm, there were 78 patients according to the 2-to-1 ratio. They looked at the time to clinical improvement, which was not different between remdesivir and placebo. So essentially, the primary outcome, which was the time to recovery based on an ordinal scale, it was an objective scale, which many people use these days for trials on COVID-19. They found that the median time to recovery was 21 days with remdesivir compared to 23 days with placebo. And this was not statistically significant, as you can see from the hazard ratio of 1.23 with a confidence interval that includes 1. That essentially means the treatment is ineffective. They also looked at all-cause mortality at day 28 as one of the outcomes, which was not different. They specifically looked at patients who had early treatment within the first 10 days to see if that made a difference. Again, although the 28-day mortality was less numerically with remdesivir, it didn't reach statistical significance. Late treatment paradoxically resulted in higher mortality with remdesivir, although again, this was not statistically significant. Surprisingly, the viral clearance by RT-PCR, you would expect viral clearance to be much more prominent with remdesivir, with a drug that acts by inhibiting the viral RNA, but that was not the case in this study. Viral clearance by RT-PCR was also comparable between the remdesivir and the placebo group. So this study did not actually show an advantage with the use of remdesivir, neither in terms of the time to recovery, nor in terms of the 28-day mortality, nor with early versus late treatment, and not with viral clearance either. So it was disappointing. But this study was not adequately powered. They did not reach their calculated sample size to attain the power that they had projected, because as we have seen with other studies from China, especially from Wuhan, during the course of the study, They say, and we have to believe them, that the number of cases came down and they could not enroll patients anymore and they had to stop the study in between. So that's the reason that they attribute for the non-completion of the sample size that they had originally projected. Anyway, this study was disappointing. Subsequently, we had this study from the National Institute of Allergy and Infectious Diseases in the US, from the Institute of Health, the ACT trial, which again compared remdesivir versus placebo in an adaptive design. And they studied a much larger number of patients. They included 1,052 patients in this study, and they divided patients in a 1-to-1 ratio, remdesivir versus placebo. The primary endpoint was the median time to recovery. Recovery was defined again on the ordinal scale that I mentioned, slightly different from the Chinese study. They took categories 1, 2, and 3 as recovery. Category 3 were patients who were still in hospital, but essentially asymptomatic and were being held in hospital only because they hadn't tested negative. So categories 1, 2 were at home, 3 were in hospital, but asymptomatic. So this is the median time to recovery. Remdesivir resulted in a lower median time to recovery, 11 days versus 15 days. So there was 4 days difference in the time to recovery with remdesivir compared to placebo in this study. Well, that was statistically significant. The 28-day mortality, which was one of the secondary endpoints, was numerically lower, or more people survived with remdesivir compared to placebo. The mortality was 8% in remdesivir versus 11.6% in the placebo group. This was not statistically significant, but numerically it was, of course, in favor of remdesivir. So this study was different from the Chinese study, much larger sample size, multi-centric study across several different countries, including the US, Spain, several other countries in Europe as well. And they came up with this interim report, which was published. And also they made an announcement in the media as well before publishing. So this study actually showed promise with remdesivir compared to the Chinese study. And there are several guidelines across the world which currently recommend the use of remdesivir in patients with COVID-19, especially among patients with severe forms of disease. One of the other drugs that has generated interest in the last few days, particularly in India, has been favipiravir, which has been authorized for use in COVID-19 in India. And it is another antiviral drug. If you look at the evidence for the use of favipiravir, you will find it very disappointing, to say the least. There is only a single controlled study that I could come across, published in a Chinese journal, published in the English language, of course, in which they did a study. It was a non-randomized study. There was a control arm and a intervention arm. The control arm received lopinavir-ritonavir, and the intervention arm received favipiravir. So they compared favipiravir versus lopinavir-ritonavir in an uncontrolled fashion. I don't know how they chose their patients. All this adds to the study bias, of course. And there were 2 endpoints that they looked for. One of the endpoints was improvement on the CT scan. So according to this study, as you see on the image, this is actually reproduced from their own published article. The improvement as evidence on CT scan was significantly better with the use of favipiravir compared to lopinavir-ritonavir. So these were the images, as I mentioned, that I have taken from their own publication. And they also showed that unlike remdesivir, the use of favipiravir resulted in faster viral clearance compared to lopinavir-ritonavir. So this is the only controlled study that I could come across. Again, as I mentioned, it is not randomized control. There is no details as to how they chose their patients to receive one or the other. But it showed that earlier CT resolution of the lesions on CT may happen with favipiravir as opposed to lopinavir, and that viral clearance may be faster with the use of favipiravir compared to lopinavir. There are several other small case series which report on improved outcomes, but it's all very dodgy kind of data, to say the least. And you will really need much larger, much more randomized control studies to come to any definitive conclusions. Although, as I mentioned, it is being authorized for use in COVID-19 in India. Of course, we must understand that it's a desperate situation. People are clutching at straws, essentially, to look for a remedy for this contagion. And as we discussed prior to starting this meeting, everything is being thrown to try to control this infection, to improve outcomes, and also to control the spread of the disease. So that's the story of favipiravir. And now we go into one of the other drugs which has been touted as a dramatic breakthrough in COVID-19, dexamethasone, which was part of the recovery study conducted across the UK by the National Health Services. In fact, the National Health Services in the UK, they study 6 different interventions with the recovery trial. These interventions included hydroxychloroquine, which we'll discuss later on. It includes remdesivir, which they are still enrolling patients for. It included dexamethasone, convalescent plasma as well. So several different modalities. And one of the modalities that they studied was dexamethasone. In fact, they reported this on the media several days ago, and they published their paper, the first preliminary paper, online on medRxiv, which is an online database of non-published or non-printed papers. It is off-print, online, non-peer reviewed. So that's the way it is available today. So what did they do? They used dexamethasone either intravenously or orally in a dose of 6 milligrams per day and administered it for a period of 10 days among patients with COVID-19. And in the control patients, it was usual care. Usual care in the UK means nothing else apart from supplemental oxygen as required. They don't give any kind of desperate interventions like people do everywhere else. They just confine to oxygen and supportive care. So it was dexamethasone versus essentially nothing. Dexamethasone 6 milligrams per day for 10 days, intravenously or orally, depending on the circumstances. And they halted the study halfway through after what they considered to be sufficient number of patients to suggest adequate power. In fact, the study steering committee called a halt to the study, suggesting that there is enough number of patients to come to a definitive conclusion and that you should not delay any further to come up with the results. And what did they find? The primary outcome was the 28-day mortality. So that's a reasonably good outcome for any kind of intervention in any kind of major lung disease with a significant mortality. They found that the 28-day mortality overall in the whole cohort of patients was significantly lower with dexamethasone compared to usual care. So that was the overall finding among all patients. Dexamethasone 6 milligram intravenously for 10 days resulted in improved survival compared to usual care. They analyzed patients, subgroups of patients, which are predefined subgroups, pre-specified subgroups of patients. First, patients who were on oxygen alone. They found, again, patients who were receiving oxygen, survival was better with dexamethasone, or mortality was lower with dexamethasone compared to usual care. And in patients with who were invasively ventilated, intubated and ventilated, again, mortality was significantly lower with dexamethasone compared to placebo. And in fact, they came up with the number saying that the mortality reduced by 1/3 among patients who received oxygen and 1/3 in patients who were on invasive ventilation and 1/5 in patients who received oxygen alone without invasive ventilation. However, they also found that in patients who did not require any oxygen, who were relatively well preserved, there was no difference in the 28-day mortality. In fact, the 28-day mortality was numerically higher in patients who received dexamethasone compared to those who did not, even though this was not statistically significant. So it goes to show this study, if you interpret this study based on the evidence or based on the data they offer us, it looks like in relatively mild illness among patients who do not require oxygen, there may not be any mortality benefit. But as the disease severity increases, there seems to be a stepwise improvement in survival with the use of dexamethasone compared to usual care, starting from patients who are on oxygen alone to patients who are on invasive mechanical ventilation. So, as I mentioned, the chief investigator of this study came up with a statement suggesting that it is the only drug so far that has been shown to improve survival in COVID-19. Of course, as I mentioned, this is only a preliminary report. We need to look at it in greater detail. And also, if you look at the overall mortality, the mortality numbers or percentage of mortality was 21% in the dexamethasone arm versus 24% in the standard arm. So the difference was only 3 percentage points, absolute difference, although it was statistically significant. And another astounding fact that they come up with is that the baseline mortality among patients who did not require any oxygen at baseline seemed to be 18%. So that's a little difficult to understand as to why patients who do not even require oxygen should have a mortality of 18%. There has been some talk that across NHS, especially in older subjects, they opt for palliation or they opted for palliation and just comfort care in many of these patients that may have actually contributed to the 18% mortality among the less severely ill patients. So we don't have those details as yet. As I mentioned, it's only a preliminary non-peer-reviewed report, and we await publication of the full study in a journal. We were discussing prior to this webinar about tocilizumab among ourselves. Again, it has been quite extensively used in India as well as overseas. The premise behind the use of tocilizumab is the fact that in many of these patients, there is a profound inflammatory response with increase in level of cytokines, including interleukins. There is HLH, and there is an increase in the level of ferritin, CRP, sorry, all of which suggest a very profound inflammatory response. And tocilizumab has been shown to suppress inflammatory action. And if that is the case, would it be effective in COVID-19? That's the question that has been asked. There has been several small studies, mostly retrospective, observational in nature, and they have shown, some of them have shown a reduced number of ICU admissions, some have shown a trend towards lower mortality with tocilizumab. And in a single arm study, there was a significant reduction in inflammatory markers, including IL-6, and improved PF ratios as well. So there is some suggestion there that it might significantly suppress the inflammatory reaction that you see in COVID-19, and that it might have a favorable response on the PF ratio and improve oxygenation. And there is also some suggestion that the earlier the administration the better it may be in terms of improved survival. This is, of course, true with most of the interventions studied so far. The earlier you do it, the better as well. So, in the absence of robust evidence, if your patient shows a inflammatory reaction, either clinically or by measurement of interleukin-6 levels, which most of us do these days, it may be appropriate to start using tocilizumab empirically. How about convalescent plasma, for which there has been a lot of interest in Kerala, I know, in Karnataka as well. At our hospital as well, we are considering, we certainly are on the way to getting to use this intervention. We are in touch with our blood bank and to try to get convalescent plasma. To find donors, of course, is not an easy task. So against this background, they performed this. In fact, there was a study that was published several weeks ago from China, which was a case series of just 5 patients. This was, of course, just a case series, and they showed some promise with convalescent plasma. But this study was a proper randomized control study in which they divided patients based on the severity into 2 categories: patients with severe illness and patients with life-threatening illness. Patients with severe illness were those with a respiratory rate at baseline of more than 30 breaths per minute, saturation of less than 93% on room air, or a PF ratio of less than 300 millimeters of mercury. And life-threatening illness was represented by the need for mechanical ventilation, patients who were in shock, and patients who had extrapulmonary lung failure. So at the start, they predefined the subgroups of patients. And what did they find? They looked at the cumulative improvement based on an ordinal scale, and they found that in patients with what they defined as severe illness, that is respiratory rate more than 30 per minute, PF ratio of less than 300, saturation of less than 93 on room air, in that category, convalescent plasma resulted in a more profound cumulative improvement compared to the control group. However, this improvement did not translate to patients who had life-threatening illness. And when they considered the cohort overall of all patients, again, there was no difference. However, as I mentioned, there is some signal that suggests that in patients with severe disease, which you may categorize as mild disease, as I mentioned, there are patients who don't require mechanical ventilation with a PF ratio of less than 300 and respiratory rate of more than 30 per minute, saturation of less than 93%. So in that category of patients, they found that convalescent plasma may help with improvement or the time duration to recovery. And they also found that viral clearance was markedly faster with convalescent plasma, as you would expect, because the plasma that they used was FFP from patients who were recovered from COVID-19 and were discharged from hospital for at least 2 weeks. And they had a IgG titer, IgG antibody titer against the spike receptor binding protein of at least 1 in 640. So they measured titers and they used plasma FFP with such titers. So it is only quite plausible, as they found in the study, that viral clearance was far superior. At 72 hours, the viral clearance was 87.2% in the convalescent plasma arm compared to only 37.5% in the control group. So definitely it seems to clear the virus, and there may be a category of patients in whom if you treat this, if you commence this treatment early, it may result in improved recovery. However, they found that there was no difference in the 28-day mortality. The total duration of hospitalization did not differ, and the time to discharge from hospital was also not different between groups. Now, we go back to hydroxychloroquine. I believe most of us still continue to use hydroxychloroquine because the ICMR still recommends it. However, it is contrary to the evidence, overwhelmingly contrary to the evidence we have available at this point of time, either in terms of treatment of COVID-19 or in the prophylaxis of COVID-19. There has been two recent reports. The first report, of course, is part of the recovery study that I mentioned. One of the study arms in their study was hydroxychloroquine, and they compared 3,000 plus patients who received hydroxychloroquine versus 1,500 plus patients in the control group. And they could not find any difference in the 28-day mortality with hydroxychloroquine compared to the control group. And so they withdrew this study arm from the recovery study, which doesn't have hydroxychloroquine anymore. So that seemed to close the chapter, but not quite. As I mentioned, not only in India, in many other countries of the world, people still continue to use hydroxychloroquine, perhaps more out of desperation than anything else. In terms of prophylaxis, there has been a very convincing study which was conducted in US and Canada among patients who came into contact with COVID-19 patients and who were exposed to a high-risk contact for a period of 10 minutes or more. And the use of hydroxychloroquine as prophylaxis within the first 3 days, I think, did not matter. The incidence of subsequent COVID-19 was similar in patients who received hydroxychloroquine and those who received, or those who were in the control arm. It was roughly 10% in both arms. So in prophylaxis, in treatment, hydroxychloroquine does not seem to help, and it may not be appropriate to carry on with this intervention anymore. So that's it in terms of the evidence we have available at this point of time. There are several good studies that are ongoing at this point. The Solidarity trial, which is being conducted by the World Health Organization, they are studying remdesivir, lopinavir-ritonavir, and lopinavir-ritonavir in combination of interferon beta-1a. The discovery study, the recovery study is still going on in the UK with several other arms, including remdesivir, convalescent plasma, and so on, still going on. So although we seem to have not really come to any definitive modality of therapy that may improve survival in patients with COVID-19, there is a lot of work going on in this area. And given the overwhelming numbers across the world, there has been no problem in recruiting patients. And we are very hopeful that a single intervention or a combination of several interventions may improve the survival and improve recovery in COVID-19. And of course, we're all waiting for that elusive vaccine, which hopefully will come at the end of the year. We need to contain the disease somehow until we are able to find a definitive vaccine. So that's it. We can discuss any burning issues on this right now. Thank you.
Thank you so much for sir, for that excellent review. Uh, Sir, my first doubt. So, with this all available evidences, like if you are getting a patient in your unit, how will you choose the available drugs in India now?
I can tell you what we are doing at this point of time, which I'm afraid may not be based on evidence totally, because we have to go by the guidelines as well. Because in a situation like this, you cannot go against what we are supposed to be doing and what is considered to be conventional practice. So we still use hydroxychloroquine in most patients, even with mild disease. And if they have symptoms, if they are symptomatic and if they require oxygen, we have started using dexamethasone as well. And we also have access to itolizumab, which is again one of the suppressors of the inflammatory reaction, like tocilizumab. We use it in patients based on the clinical judgment of the treating physician. Convalescent plasma, as I mentioned, has not yet been available, so we can't use that. We have been able to get remdesivir in some patients. So it is a mixture at this point of time. They start with hydroxychloroquine still. Dexamethasone has been added in the last few days, and plus minus remdesivir as well, and convalescent plasma we may get access to in the near future. So that's the way we carry out in our hospital at this point of time.
And sir, like one question, tocilizumab, where exactly will you start? Will you wait for the cytokine storm to develop and look for any H score or some other score to establish that there is a macrophage activation like syndrome or cytokine storm, including the IL-6 levels, all those things, or clinically only depending on worsening hypoxemia or worsening infiltrates, will you go for tocilizumab?
It's a very relevant question, but unfortunately, there is no clear-cut answer. I know. People have been going by IL-6 levels, ferritin levels, etc., as a marker of the inflammatory response. That is perhaps the best we can do at this point of time. There is no other indication as to what may be an appropriate time to use it. There are several theoretical postulations that suggest that in the initial phase of the disease, when there is no marked inflammatory response, it may not be beneficial, and that the cytokine response usually happens later on during the course of the disease, and it may be more effective at that point of time. It's only hypothesis generating at this point of time. As I mentioned, there are no clear-cut answers, and conventionally, people go by interleukin-6 levels and ferritin levels. We do that as well. But is that the best way forward? I don't think anybody knows the right answer at this point of time, unless we have more robust studies. There are hardly any at this point of time. Unless we have more robust studies, I don't think we will be able to answer that question reasonably accurately.
What about this awake proning, sir? Like, are you started doing that?
Yeah,
Are you
we have done that in the last maybe 5 patients or so. And what we have observed is that there is definitely an improvement in the PF ratio, oxygen saturation, and especially among patients who are okay to lie in the prone position for extended periods of time. It's a good option. If the primary problem is desaturation and low saturation, they would improve. Many of them do improve with awake proning. And sometimes they seem to improve in one lateral position or the other as well. So that is also another option. So it depends on the situation. You obviously cannot force your patients to lie in a prone position if it's uncomfortable for that person. So depending on the comfort level of the patient, willingness to lie prone at least for 2 or 3 hours at a time, it's a reasonable option, I think, if the predominant problem early is low saturation. And by the time other treatment modalities kick in or the disease itself settles, hopefully you can avoid intubation, invasive ventilation, and so on. High flow nasal cannula can obviously be used in awake prone patients.
sir, between HFNC and NIV, like what is your practice? Like how will you opt? Like which are the situations where you prefer HFNC over NIV?
It's again a very important question. I think the experience across the world is fairly limited with trying to make any kind of conclusion at this point of time. But one of the real concerns with the use of both high flow nasal cannula as well as non invasive ventilation is that you may continue with it for a unduly prolonged period of time. And especially in a situation where the level of monitoring may not be adequate, when obviously you cannot be by the patient's bedside in a situation like this. And it's very easy to miss out worsening or impending worsening in patients who are subjected to non-invasive ventilation and high flow nasal cannula. And if they go on worsening and if they they go on worsening unnoticed. And then finally, if you scramble at the last minute to intubate them, the results are obviously not going to be good. And this has been substantiated in COVID-19 as well as in other viral pneumonias as well. The longer you delay in a patient who's deteriorating, the worse the outcomes are going to be. And in fact, I was listening to Luciano Gattinoni the other day, the one of the most experienced people in this area. He was also suggesting that you might perhaps give a short, brief trial with high flow nasal cannula in an IV. And what he would look at is the level of patient comfort. If the patient becomes more comfortable, the predominant thing that you would need to look for is the intensity of the respiratory effort. If they continue to have vigorous inspiratory efforts, the transpulmonary pressures will rise, and that can give rise to what's called patient self-inflicted lung injury, which can worsen the disease process with vigorous spontaneous efforts. And as I mentioned, this can very easily go unnoticed. If you're not careful, if your nursing personnel, if your junior doctors are not able to identify the, the vigorous respiratory effort, it might end up causing serious problem with your patients. So you can give a brief trial for a couple of hours, 2 or 3 hours. If there is no significant improvement by the time, if they remain unchanged or if they worsen, I think personally it's best to go ahead with intubation. At least that's what we have done as well in our unit in the limited number of patients that we've had so far who required mechanical ventilation. So patient self-inflicted lung injury is for real. It can cause rise in transpulmonary pressures and worsen the picture if you persist unduly for an unduly long period of time with any of these spontaneous modalities.
Sir, to continue with that, like the so-called L group of patients without much significant chest X-ray infiltrates, if they are comfortable with almost 100% FiO2 in high flow nasal cannula and saturating about 88%, can we allow them to continue like that, or is there any cutoff? Like I usually don't keep the patient on such a high FiO2. So do you feel that in such a particular group of patients, and the way you described, if the patient is like reasonably comfortable, can we recommend to continue with the HFNC even if it is such a high FiO2?
Patient is severely hypoxic, requiring nearly 100% oxygen, but reasonably comfortable. That's what he said, isn't it?
Yes.
Perhaps in that situation, what I would do is I would continue for a little longer. If I am able to observe this patient very carefully, which is extremely important, and if they seem to improve, you can press on. But if they continue to saturate poorly, in spite of several hours of persistent treatment with high flow nasal cannula, there would be a serious case to intubate them and continue with invasive ventilation rather than persist with high flow nasal cannula. It all depends on the individual clinical situation. One size obviously will not fit all, and it depends on your own setup as well, the experience of your doctors and nurses as well. And I think if you're unable to monitor them closely, it may be, again, depending on your circumstance, it may be safer to intubate and ventilate them. And the studies which have come up lately, in contrast to some of the early studies which suggested a very high mortality for invasive ventilation, at least the recent studies, especially the recovery study, does not show such a high mortality. It's about 40% on ventilated patients, which is roughly similar to any other type of viral pneumonia. So people are gaining experience with COVID-19, and you need not consider that intubation ventilation is a death sentence. That's not the case anymore.
Because like everybody is having this fear, sir. Like even if you intubate, obviously the mortality will be really high, and again managing such patients also will be difficult. So go with the maximum FiO2 possible with NIV or HFNC, and you try to delay the intubation. So I think that may be sometimes harmful, no, sir.
That is true. As I mentioned, it depends entirely on the kind of facility that you have. If you're overwhelmed with hundreds of patients and you are running short of staff, equipment, ventilators, and so on, the best you can offer is obviously oxygen, more oxygen, high flow nasal cannula, non-invasive ventilation perhaps. That's what they did in many countries, including Italy, China, when they were overwhelmed at that time. So if you have such a situation, which is possible in India in the near future, it may not be feasible or practicable to intubate, ventilate them, and you may have to compromise with just oxygen and non-invasive modes of therapy.
And sir, one more doubt, not exactly related to the medical management aspect, related to the infection control part. In the ICU, like, what is your the way of practice now? Like, you provide at least surgical mask, face shield, and N95 for all the medical staffs in the ICU, or like only for the areas where you take the positive cases?
We have two areas. They are physically separate from each other. In the COVID area, in fact, all admissions are initially made to the COVID area and they are tested with TrueNat, which is the results will be available in 2 or 3 hours, or with RT-PCR. And only after the screening would they get to the main area of the hospital, which is a clean area of the hospital. So in the COVID area or the screening area, every person uses full protective gear, including gowns, N95 masks, including face shields, the full suit. So that is the practice that we have in the COVID area. Even in our general ICU, we use these precautions all the time, including gowning, N95 mask, and face shield, because in fact, we had a case just recently, a patient who had a 30-plus-year-old man who presented to us initially with cough, breathlessness, and bilateral infiltrates on the X-ray. He tested negative, so he was transferred to the main area or the clean area of the hospital. But there was a strong suspicion in this case that the first test may have been false negative. So we took adequate precautions in this case. We took full precautions with the full PPE, including the full suit, to take for all personnel who was involved in his care. So I think it's a reasonable precaution because, as we have seen, even the RT-PCR, which is the gold standard, by nasopharyngeal or throat swabs may be false negative in about 30 to 40% initially. If you do a tracheal aspirate, you will get much more positivity. So in patients in whom the clinical picture suggests strongly that it may be COVID-19, it is very important to take adequate precautions, even if they test negative initially, till you are sure.
Sir, while triaging, even the patients without COVID-like symptoms, also you take them to the COVID area, or you take them to the clean area?
Now, all patients in our hospital, they go to the screening area first. They're all tested, and only if they test negative for any condition, be it breathlessness with, say, pulmonary edema or renal failure, ESRD on dialysis, fluid overload, they're all tested. And only if they are negative would they come to the clean area. That is the practice that we follow.
And sir, while that screening, like the way you told, even if the test is negative clinically, if you think there is a high probability, so what will you do? Will you keep the patient in the COVID area, or will you shift to the clean area?
There are two options. First, if the index of suspicion is extremely high, we would tend to continue in the COVID area. We wouldn't transfer them till we get a second report. If the index of suspicion is low, they would get transferred to the main area or the clean area.
And this COVID area, like your tested positive patients also you keep there?
Yeah, they, of course, in the COVID area, all the tested patients who are tested positive, they continue to be there. So they have separate single rooms. Okay. They are in single rooms. They don't mix with the general patient. Yes.
Because if you don't have a single room, that will be an issue, no, sir. You may
We
not use
have
it.
single rooms. It's
Yes.
not negative pressure, but they are single rooms.
Okay, sir. Thank you. Sir, there are many questions. The first question is regarding the dexamethasone. Whether do you think that is better, or depending on the previous IRDS trials and all, the previously described IRDS dose of
Methal.
methylprednisolone will be better?
Well, all we can say at this point of time is that dexamethasone has been studied and it's been shown to be possibly beneficial in terms of improving survival among patients who require oxygen and patients who are ventilated. So it's best to stick with that. And in fact, with methylprednisolone, if you look at the data available so far with other forms of viral disease similar to COVID-19, like H1N1 pneumonia, the results have been very disappointing. In fact, if anything, methylprednisolone in the doses that we commonly mention has been associated with increased mortality in other viral pneumonias. So there is nothing to suggest that it may be effective with COVID-19 patients. And we have some signal of evidence, at least, that dexamethasone may work. And I think we should stick to that for this at this point of time.
So the next question is regarding the antibiotic use, especially when the patient develops a cytokine storm with fever, tachycardia, all those features of infection. How will you clinically decide whether to give antibiotic or not?
I would say that in most patients who present with these features, bacterial infection is highly likely, and it is reasonable to commence them on antibacterial therapy at this point of time. You need not use the industrial strength antibiotics to begin with. You can use a third generation cephalosporin, azithromycin as well. I'm not suggesting azithromycin to kill COVID-19. It is just as a pure antibacterial therapy. So it's reasonable to do that. I think that's the practice across the world as well. In severely ill patients in whom you cannot tell if there is bacterial infection or not. And super infection with bacteria is extremely common in viral pneumonias. So it is best to be safe in patients who are severely ill, hypoxic, requiring oxygen, and cover them with antibacterials as well.
Sir, another brilliant question. Like especially when you go with early steroids in the early time, so whether it is going to increase the viremia and the subsequent complications. Because if you suppress the immunity in the early phase of viremia, it is likely that the viremia can flare up. So what is your take on that?
It is theoretically very much plausible that if you use during the viral proliferation stage, you might actually worsen the viremia and worsen the clinical picture. In fact, as I suggested in the recovery study, it seemed to suggest that early treatment does not help, and there is a possibility that it may harm as well. The numbers were actually numerically, the 28-day mortality was higher with dexamethasone in patients who did not require oxygen at baseline. So that is something that needs to be studied specifically. And certainly you wouldn't use steroids, I wouldn't use personally, in patients who do not require oxygen and you have only mild symptoms. I don't think it is recommended at this point of time. You would use it only among patients who have more severe forms of the disease, including the requirement for oxygen.
And sir, one last question again, nothing directly related to the medical management. Like especially when we treat these COVID patients to reduce the exposure of more people, like what are the changes what you made in terms of oral care, feeding, other general ICU care for that COVID patient?
Um, of course, you should restrict the number of personnel who get access to the patient. Our nurses do 6-hour shifts, and we have we communicate with the nurses. Our doctors communicate with the nurses as much as possible without physical contact. Of course, you will need to be in physical contact during procedures, intubations, line insertions, and so on. But a lot of information can be transmitted without actual physical contact. So that is one thing, restriction of staff, and adhere to the PPE guidelines all the time. Do not drop your guard even for brief periods of time, as uncomfortable as it may be. And we have cohorted our nursing staff as well as medical staff. There is a cohort of staff who take a week on. Our doctors do that, a week on, and they take a week off after their schedule of the week. So the nurses also, after their shifts, they do not come to the general area. They stick to the COVID area as well. So these are some of the precautions that are simple to carry out and practicable by the bedside, just to name a few.
Sir, some of our attendees are asking for your email ID, sir. Can you just type your email ID?
Type it down on
Chakkojos
this.
at email.com.
I'll just type it on the screen. I hope that is visible.
Yes, it's visible.
All right.
I think you can see the in blue, sir has already typed. That is sir's email ID, and the blog ID is also given. And sir, one more question regarding the asymptomatic patients with or mildly symptomatic patients without hypoxemia with CT findings. So incidentally, for any other patients like a trauma or any other situation, they come to your hospital and the CT is showing like ground glassing, peripheral shadows, something suspicious of COVID. So what will be your line of management in that patient?
That's a very important question. Patients who test negative, but they have features on the CT scan which look very strongly suspicious of COVID-19. I think in that situation, it's very important to consider the patient to be COVID-19 infection, because CT has been shown to be very sensitive to COVID-19 pneumonia in many studies, especially in large size studies from in the initial phase of this pandemic from China. They showed that CT may be even more sensitive than RT-PCR in the initial stage. So if you get the typical ground glassing, peripheral ground glassing, patchy opacities, patchy consolidation, crazy paving, and so on the CT scan, it immediately raises a suspicion, and you should increase your level of vigil to a, a strong possibility that your patient may be COVID-19, and all staff members should take appropriate precautions to prevent spread, to prevent transmission to themselves and transmission to others as well.
I think, sir, with one last question, we'll conclude. Like your personal experience in ventilating the COVID patient compared to other viral pneumonia patients.
From what we have seen so far, it doesn't seem to be very different in terms of the modality of ventilation, the ventilator parameters you set, or the requirement for prone ventilation. In fact, we had 2 or 3 patients who required proning during this period, and they did respond to proning as well. So it didn't seem to be vastly different. I don't think we came across patients who had preserved lung compliance with extensive lung involvement, unlike what the initial observations were from Italy. Patients who were severely ill had poor compliance among the patients we have seen so far. So nothing very different compared to what you would normally expect in a viral pneumonia. And the modality of support and the level of support has been pretty much similar. Of course, you need to persist and wait patiently for improvement. And this disease, one must understand, doesn't get better in 1 or 2 days' time. Once they require ventilation, they will require at least several days for improvement to happen. And you should be willing to wait, even though their oxygenation may improve with PEEP, with proning, and so on, doesn't necessarily mean they can be weaned off immediately. They may take their own time to get better, and you need to be patient and wait it out.
Oh, thank you so much, sir, for that excellent discussion where we have covered almost all ICU aspects, even though we started with only the medical management. And thank you, sir. Thank you so much, sir. And thank you, attendees, for patient listening. You all have interacted well. Anyone has any particular question to Joe, sir? If you raise your hand, I can unmute you. Any relevant question other than what we have discussed, or like any case scenario, something if you want to discuss or something related to COVID? If you raise your hand, I can unmute you. Okay. No questions. So thank you so much, sir, and good night.
Thank you very much, Sanup. It's been my pleasure to be here this evening. Thanks everyone for attending. So see you next time with a new, equally interesting topic. Thanks everyone.
Thank you. Good
Thank you
night.
very